Hello, everyone. I'm Melissa Beck, the Executive Director of the Sozosei Foundation, and we are so happy that you've chosen to join us today for our inaugural Sozosei Summit Solution Lab, 988 and Other Numbers, What the Data Tells Us So Far. As you all know, the Sozosei Foundation is dedicated to the decriminalization of mental illness. We believe that 988 is central to that goal as it has the potential to help ensure a non law enforcement response to a mental health emergency. Launched in July 2022, 988 is absolutely a work in progress. And research, of course, plays a great and important role when a work is in progress because it helps us to course correct, learn more, and advance a world where mental illness is not a crime. The researchers who are with us today bring a level of expertise and frontline knowledge that is unparalleled, and I think you'll find today's conversation informative and illuminating. If we could please move to the next slide, I'd be grateful. We have a little housekeeping to look at. Everyone who is participating today is muted. If you have a question during the conversation, please put it into the Q&A section of your Teams portal. We also received many pre-event questions and will be addressing as many as we can, both from before and during the event. Should you have any technological difficulties, you'll see the name, the email address, and cell phone number of Karen Powell, who's standing by to assist you. To the next slide, I want to, of course, let you know that our Sozosei Summit is fast approaching April 16 and 17 in Philadelphia, Pennsylvania. The event is now at capacity, but we do have a waiting list that you can join by visiting sozoseisummit.org and, of course, following us across our social media channels. Now, back to today's event. Next slide. We again have wonderful experts who are going to be talking to us about the state of 988 as of today, March 1st, 2024. I'm not going to go through their biographical statements because you have all received it. Suffice it to say, we are in excellent hands today. And a final quick glance at the agenda before I turn it over to our moderator. The panel will be in discussion until about 12:55, at which point we will turn to Q&A from prior to and during the conversation. Once again, please put it in the Q&A box on your Teams portal. And with that, I'll turn it over to Eric, who has graciously agreed to moderate this conversation. Eric, welcome and many thanks.
Thank you, Melissa, and great to be here, and I'm really honored to have this opportunity to talk about this national effort with everybody. So we're going to start off. I'm going to hand it over to Monica, who is going to give us some updates on where 988 is and has been over the past year.
Sure. Thank you, Eric. Hello, I'm Monica Johnson. I am the director for the 988 and Behavioral Health Crisis Coordinating Office. Try to say that real fast at SAMHSA. I've been in this role for a little over a year. Our office was a new office. And so not only with the implementation of 988 on July 16th, we're almost approaching 2 years in July. So we are a new office as well that came along with the implementation. So excited to be here today to have this conversation with my colleagues here today. We thought we'd do a little bit of table setting around just reminding people what 988 is and where we are kind of today. And I think I'll take a second or two to just highlight some priority areas that we're looking at this year. So our office is charged with the federal administration of 988. And so for us, that means two distinct different buckets. One is obviously operational oversight of the Lifeline. We do that through a cooperative agreement with Vibrant Emotional Health. And so a part of our charge is making sure that 988 is something that no matter where you are in this country or U.S. territory or tribal community, that you can use 988, you can call it, you can text it, or you can chat when you are experiencing any type of emotional distress. 988 obviously was the transition from the previous 10-digit suicide prevention number. 988 gives us a way to be able to have a standard way in which we know that we can access, we collectively, any of us that are experiencing any type of emotional distress. So rather that is for thoughts of suicide, depression, anxiety, grief, whatever it may be, concerns about substance misuse. We now have a 3-digit, easy to remember number for anyone to use in this country. I've been working in behavioral health for 27 years. I've done this my whole adult life. I've done all the different roles. And what I can say with full confidence is this is the most transformative initiative that has happened in behavioral health. Having an easy to remember number, just like we know what 911 is, having a number for when you are experiencing a behavioral health crisis that you can call, text, or chat is critical. So the second part that leads to the second part of what we're responsible for is no big deal, but it is behavioral health crisis transformation for this country. And so 988 then is a catalyst for what we can do and how we respond to when an individual is experiencing a behavioral health crisis. We want people that are experiencing a crisis to have the right response. Oftentimes, 911 is utilized, and we know that individuals can be diverted from a law enforcement response and should receive the appropriate healthcare response when they are receiving or experiencing a crisis. So that is the promise of 988. And so what that means and what we have seen is that every state in this country, you can check me, you can go watch legislation that's happening out there, is doing something related to what does my behavioral health crisis continuum look like? What does this mean? So 988 then becomes more than a 3-digit number. It becomes a game changer in around how we talk about behavioral health care and how we talk about what happens when someone experiences the behavioral health care system when they are in a crisis. It also causes a conversation about, well, what are we doing before the crisis and what are we doing during the crisis and what happens after? And so we have a three-pronged approach in the way this work happens. There is the call, the text or chat, put that in one bucket. But then there is also what is the response? So typically that may look like mobile crisis. The third leg of this prong is related to, is there a place that I can get help when I need that, if that is the appropriate response? So since the launch of 988, we have received over 8.3 million contacts. That includes all text, chats, and calls combined. We've expanded to subpopulations. We could continue to do that work to make sure that everybody can get access as they need. I'll wrap up this quick, very quick table setting with a look ahead of what we're trying to do this year. These are our priorities. This is not an exhaustive list. I just don't have time to tell you them all. So here are the top ones. In this year, and when I say year, I'm talking about a calendar year, we're focused on the implementation of geo-routing. We'll talk about that, I think, throughout today, so I'll come back there. We are updating the crisis guidelines for states and territories to have access to. The last version was 2020. That was before 988 and prior to COVID. We are working on making sure that our workforce is being supported. We know that there is more demand now. We know that that impacts the way helpers who are helping others or that are working feel. And so burnout, workforce challenges, et cetera, we're really working to hone in around that area. We want to continue to raise awareness about what 988 is and what it is not. And then we want to make sure that we're beginning to answer questions related to outcome. We have some robust evaluation and research ahead to really tell us what this all means. So I look forward to spending this hour with you and turn it back over to Eric.
Thank you, Monica, and great job condensing so much impressive work into just a few minutes. I'm going to hand it back to you for a moment because we're going to talk a bit about what types of data we're looking at. I know you talked about the vast number of contacts that has come in. And so from a federal level, how has that compared to the numbers of contacts that came in previously? And how have there been changes to wait times? My understanding is that has actually significantly decreased, which has been quite an accomplishment considering that the contacts have gone up so much.
Yeah, so a couple of things here. So we monitor key performance indicators related to how the overall system is performing, so the health of the system. These include a number of metrics, but we're looking at contacts that includes calls, texts, and chats. We look at the number of contacts that get a response. We look at the length of time that it takes to initially respond. And then we look at the length of each of the call interactions, the text, and the chats. For local response, we do monitor how each state is performing on these measures. Most of this data is public facing. It is on our website, on SAMHSA's website. If you get to the 988 landing page, it will take you to all of this data. We also monitor information for our subpopulations. So that would be LGBTQI plus population, Spanish language, and then we recently added ASL video phone services for individuals that are deaf and hard of hearing, and for which ASL is their preferred mode of communication. So, what we're looking at and what we know has happened so far, and I said a little bit of this earlier, that since the transition to the 3-digit code, we are now seeing more people access care. We see that they're getting to the care faster. I think I quoted 8.3 earlier, and I actually think that's 8.6 contacts to January of this year from implementation. So a little over about a year and a half. So in the first year, even with 2 million more contacts than the previous year, the response times went from 2 minutes in about 39, 40 seconds, now down to 41 seconds. I'm gonna repeat that. We went from 2 minutes and 39 seconds to 41 seconds response time. So I think there's some good examples of some of the things that we're looking at. It's not all inclusive, but those are just some key highlights.
Thank you. Thank you. A lot of information there to dig into for sure. I'm going to switch now and launch sort of that same question to some of our folks who have been tracking how jurisdictions and local jurisdictions and states have been implementing this. And another piece too is that although 988 is a broad national effort, kind of coalition initiative, the interventions on the ground are really state and local driven. So we have seen different models and different approaches taken in different places. And so Ted, I'll hand it over to you for a minute. I understand that you and your team have been sent out surveys to all of 988's kind of area, all of the states and territories abroad. And so what have you seen out of that data so far?
Thank you. Well, we've been surveying the state mental health authorities who are responsible for administering 988 and implementing the crisis continuum that Monica talked about. And I think what's been terrific is the national guidelines on crisis services that she referenced that talks about that three-legged sort of stool. The call centers is the crucial first hub, but also the mobile crisis teams and having a crisis receiving facility that police and emergencies and mobile crisis can take someone to, as opposed to an emergency room or jails, has been really incredible. And we're just completing a report for SAMHSA and with states on the 2023 sort of snapshot of all their services as of last year. And it's showing a tremendous increase, as she was saying. The number of calls to 988 is going up quite a bit. But I think it's also important to remember that many states also are continuing other crisis call lines that are continuing to take calls and dispatch mobile crisis. In 2023, there were 400 and some other call centers taking calls, and they collectively took 2.8 million calls from individuals in crisis. And in many states, those are the centers that are dispatching mobile crisis and coordinating with 911. We were not trying to replicate what SAMHSA is getting from Vibrant on all the call centers, but the states were interested in some of what is the impact after somebody calls. And the data there is looking very good in that 66% or 67% was the median. 63% of all calls ended up, 87% of calls were resolved during the call where they did not need to dispatch anybody at all. Often they are able to make a referral for outpatient services. About 24% of calls ended up with a referral for outpatient services, substance abuse or mental health. 7% of calls ended up with the mobile crisis dispatch, and only 2.1% resulted in law enforcement being dispatched, with 23 states reporting that, and 1.6% ended up with emergency medical EMS services being dispatched. So it really does look like it's been a great job of helping divert people from having law enforcement respond. There's a lot of work going on, and SAMHSA is sponsoring it with how does 911 and 988 interact? How do you set up decision trees for when you need to have law enforcement there for safety? But an awful lot of mobile crisis work. We've seen an increase in over 400 more mobile crisis teams set up in the last year. There's now over 1,640 some mobile crisis teams across the country. Every state, save one, said they have a mobile crisis going on right now, and that was a state that's very rural and trying to figure out how you do it still. So I got a lot more data, but let me turn it back to others. But just as she said, I think the biggest challenge we're hearing, though, is workforce to get them staffed 24/7. It's the second and third shifts for call centers is a challenge. It's really a challenge for mobile crisis teams when you're setting up all these teams around the country to respond, especially in rural and urban areas. So while we have all these crisis teams, they're not available to everybody in a state, and they're not available 24/7 often. So while the calls can be answered 24/7 anywhere in the state, the next part is where we're really struggling and working to try and expand it to make sure that it doesn't matter where you live or when you're having the crisis, that you can have a response.
Thank you. And as a reminder to the audience, the reports that are referenced here, the ones that are published so far, you should have gotten a link to that, and if not, you should get one in the post-event email that you'll receive from Sozosei. So you don't have to worry about memorizing the statistics. We'll talk in a minute about what some of these numbers might mean. I know we're throwing a lot of numbers at everybody. But before that, I want to head over to Stephanie to get an even more kind of on the ground approach. So Stephanie, I understand that you and your team at RAND looked at what localities, whether counties or local jurisdictions, were actually doing in their response, and kind of compared and contrasted what 3 different states were doing. So could you walk us a little bit through some of those differences and what that kind of meant in your findings?
Sure, absolutely. Thank you. So yes, we did. We're just wrapping up a project that was funded by the Pew Charitable Trust and really focused on what Ted just referenced, that idea of 988 and 911 interoperability, and not just the process of how calls are transferred, but really knowing how that plugs into the local continuum of care. I think that one of the things that really stood out to us in the work was that even though there are some high-level guidelines that were very similar across the 3 jurisdictions we worked with, the approach that people are taking really depends a lot on local and state policies and also on the local resources that are available. So we intentionally selected 3 sites that were pretty different with respect to geography and urbanicity and the model of 988 and 911 interoperability. And what we found was that there are some decisions that need to be made kind of across jurisdictions. Having a collaborative planning process that brings all of the stakeholders together in a room, making decisions about what a concept like imminent risk looks like. That idea of what is the inflection point between deciding whether it's a call that public safety has to respond to versus perhaps could be handled by 988 or by mobile crisis. But from there, people are really looking at what their local resources are in terms of being a rural area. Like, do they have mobile crisis 24/7, or is that something that they're working towards? What is the role of co-response teams where law enforcement pairs with a clinician to go out on some of these calls? People are starting to get creative about workforce and staffing some of these places are offering very competitive pay as a way to try to increase staffing. Some places are moving to remote call centers so that you don't have everyone sitting in a room as you might think of with a call center. It allows for some flexibility in staffing. We found also that, more and more, uh, they are finding there's been a lot of concern on the part of PSAPs that they're going to transfer calls to 988, and then the call is going to end up being transferred back to them. PSAP call takers really care deeply about the calls that they take. They feel a sense of personal responsibility for every single call. And so being able to share data at a local level, not just these overall numbers we've been talking about, has been a really critical element to this, because it's allowed call centers to say, like, look, once you transfer a call from a PSAP to 988, we actually are able to resolve 95% of these in some cases that we spoke with on the phone without having to do a transfer back. And I think that's helping to really build trust between these different agencies and increase the utilization of 988 that much more in these communities. I think that one of the things that really stood out to us is that though 988 is becoming more well-known nationwide, there are still a lot of people for whom 911 is the number that's stuck in their head as who they call when there's an emergency. And so having these types of options for collaboration between 988 and 911 creates a no wrong door approach, where no matter what number they call, they are eventually able to get to the service that's appropriate for them at that point in time.
Thank you. Thank you. I really want to highlight something you said, was the importance of having all of those stakeholders in the room. The something we found in California is that a lot of these stakeholder groups weren't used to talking to each other and use different terms and different language and kind of approach things differently. And then perhaps even had different sets of regulations around that, whether it's privacy of information or how information can be communicated to other parties. So in California, we've been lucky that the voters have put in place a legislature which fairly unanimously passed a bill recently, the Miles Hall Lifeline and Suicide Prevention Act, named after Miles Hall, who was a young man in Walnut Creek who was shot and killed by police, sadly, after his mom had called for help to get him to the hospital. And from that, the advocacy for this bill, and which really has kind of answered some of these questions in California. So now we're supposed to have 24/7 mobile crisis everywhere, and we're supposed to have these types of things, and putting it into action has been the name of the game. And so one of the things I think has been really useful is that the local leadership at the local and state level has kind of forced through this legislation, has forced all these groups together. And so there's a 988 911 interoperability work group that has both the PSAP and the call center and the healthcare folks, as well as like the law enforcement folks, in one room, and being told you have to come up with a set of definitions so that everyone on the 911 side and everyone on the 988 side both agree that can agree on the same call, which side it should fall on.
Absolutely. Sorry, that's absolutely one of the key themes we heard over and over, that these are agencies that are staffed by people with very different backgrounds, disciplinary backgrounds, lived experience backgrounds. And so it takes time to bring people in a room together and develop that shared language and develop that shared culture. And people talked about how valuable it was to take sample cases and walk through them and talk about how different agencies would approach them, and then figure out what's going to be the new approach to this type of case moving forward. It's the amount of time and effort it takes to bring people together like that can't be underestimated. It's not something that can be done overnight.
Mm-hmm. Yes.
Eric, can I weigh in here a little bit? It's such a good point, and I don't want it to fly by. When I said that 988 was transformative, these are the type of examples. There's a ton of things we could lift up, but this collaboration conversation is so critical. And I don't know if all of this was intentional or by design. Collaboration should have already been happening, right? Prior to 988, these contact centers existed. We had law enforcement, obviously, that existed. Some of these mobile crisis teams, behavioral healthcare providers, all of these things were in the system in some way. But to force this level of collaboration, or via support through legislation that you just designed, this is not like typically what is heard of. This only typically happens when you're under a lawsuit or you're forced to make these changes in your system. But people coming together and actively collaborating, actively trying to understand each other's language, actively respecting the perspectives that each of the disciplines, brings to the table, this is not the norm, and this is really important to lift up. And I think there's room for everything. So we were talking about co-responder models because it's going to take, this is not, people are not going to know about 988. Every person in this country is not going to know about 988 overnight. And so to the point that was made earlier, there are plenty of people who don't know. And so as we continue to educate, we know for a fact that it's going to take time for people to unlearn some behaviors. We call 911 for everything. You can have a power outage and that may be an emergency to you and you call 911. So this is decades of learning, right? And so now we have to relearn how to maybe divert to something else. But knowing that that's going to take time, we then have to be working in close partnership with law enforcement because that still may be a point of entry. And if that response can be coupled with behavioral health expertise, that's what we want to happen. So I just didn't want that moment to pass. And those points were really good.
Mhm. Yeah, for the California law, I'll point out that even though it was signed into law by Governor Newsom a little over a year ago, it has a 5-year implementation process to allow all of these kind of things to happen. So I want to talk a little bit about the very first step of the crisis continuum of care, the call centers themselves. And so this is, I think, very different from 911 in that although they are locally distributed or they're locally ran and kind of all across the country, they are connected to a federal backup, a federal partner, which is different than how 911 and PSAPs are. So Monica, could you talk a little bit about that structure and also the folks that are in them, the crisis counselors, this very first sort of, first line of contact and care for people in crisis that reach out. How do those folks get supported and trained and choose to pursue a career as a crisis counselor?
Sure. So there's about 200 crisis contact centers across the country. And like to your point, the calls are routed to those contact centers based on right now area code. We hope to change that soon, but by area code, and they get connected hopefully to a local contact center. So my area code is a Georgia number. I should get connected to the contact center that is where I live, which is in Georgia. And so with that being said, the individuals that can staff these contact centers can vary. Some use volunteers that are trained, they're crisis counselors. So some are trained through voluntary work, but many are also licensed clinicians. I'm a licensed professional counselor by trade. Some are associate licensed individuals, but they all go through different various forms of crisis training. I do think that crisis training continues to evolve. I think as we continue to grow and we see different types of acuity, that training is needed ongoing. And so these are people that are dedicated, that are caring, that are committed to helping individuals when they are in a crisis. If you've never visited a crisis contact center, you should. Like, you get to meet the most incredible people. I get to do this all the time. People who are on the phone or receiving, a text or responding to a chat that on many times when someone is having their worst day. And so these are heroes that often are in the shadows and don't get lifted up. So I do want to take a moment to just recognize how critical what they do is. But they need our support. They need ongoing support. They need it locally. They need it from us because this is going to continue to grow. You heard me reference the numbers earlier in terms of the volume. And so as a therapist myself by training, I think about who's helping them. And so I'm constantly asking those questions so we can be informed on how we support our contact centers, along with Vibrant through our agreement as they oversee that network.
Mm-hmm, mm-hmm.
And I do want to say, because I do want to level set that we do spend a lot of time talking about this because it's important, burnout, workforce challenges. I want to say that we've been talking about burnout and workforce in the behavioral health field for a very long time and before the pandemic. And so this is not a new issue that people are grappling with. And what I know from experience is that I went through COVID as a behavioral health director in a state authority agency, and the system didn't break. You know who still was working? The contact center workers, the mobile crisis teams, the crisis receiving facilities, the crisis stabilization unit, they were still working. And so the system didn't break when we thought it probably was at its most vulnerable time. And so it introduced us to new ways in which we could support that part of the system. And some of it you heard about earlier, being more creative and thinking about how you can lure people into the workforce. You have to get into these schools, get into the education systems to make people understand what options are out there. When I came through undergrad and master's degree stuff, I had no clue about this level of work. I thought I was going to be a play therapist somewhere, just taking money and no insurance. That's what I thought I was going to be doing. And so people often don't even know that come out of school. So you got to expose people to the possibilities of what you can do to make a difference.
Yes, yes, the wide open world of public mental health. The something I think that does strike me that for specific for 980 is that historically the system did not get much kind of sustained funding at a national scale, and a lot of call centers were operating on a volunteer basis. And now that there is more sustained funding, both state and federal, there's been a transition to reimbursing the folks that are performing their services, and for them to have more of a professional voice and role. Sorry to leave you out in the cold for so long, Dan, but I've been waiting for this point to loop you in as both as a former crisis counselor and as someone who, and perhaps still current crisis counselor, and someone who is just completed a survey of a number of crisis centers and the crisis counselors that work in those centers. Could you tell us a little bit about the crisis counselor experience over the past year and what you found?
Yeah, absolutely, Eric. Well, the study, which you can find at CrisisCrowd.org, the report which put out a few weeks ago, I think first of all, it really highlights what Monica was just saying about how the folks at the front lines, the crisis counselors at the contact centers, are doing incredible work. And actually, in the survey report, you can find a lot of the narratives and a lot of the quotes of counselors saying at length why they love the work, why they do it, how effective they feel they are able to be, how helpful they find themselves being. So I think a lot of what came out through this study of counselors. So it was we got responses through the survey through folks who have served at 20 different crisis centers. So close to 10% of the system. And as Ted was saying, a lot of the calls and the texts are coming in through numbers other than 988, as well as coming in through 988. And so we had representation on both of those. But really, a lot of counselors were talking to the same themes that we've been talking about in the last half hour. So when it comes to mobile crisis, a number of folks said it has been transformative, that there's greater availability of mobile teams, and there is much more of a crisis continuum of care where they are. I think one of the problem points for some crisis counselors that they expressed through the survey, and this was especially folks who were working at a national contact center. So many and often most folks are getting served locally, but some people are choosing to connect with a special population center that is national, and so they're not necessarily speaking with a local council. Or as Monica was explaining, there is a backup network when there is higher volume. And so a number of counselors who work at a national center said that they actually do sometimes have difficulty knowing enough about the mobile crisis options available where the person they're on the line with is. And what that can look like is if you do know, then in a conversation about voluntary intervention or a conversation about coaching someone toward considering the option of getting help from mobile crisis, potentially you can contact them yourself, or we can contact them together, and let me tell you what to expect, and which includes the counselor being confident that there is a team there, that the team is available right now, that we're within the hours, that the person that they're speaking with is within the geographic bounds for that team, and having some knowledge about what to expect, what the composition of that team is going to be, or should you expect there to be a police officer on it or not, and so on. When someone is working locally, a crisis counselor is at a local center and speaking with someone in their community or in their city or region, they're much more likely to have that information. And it can be a challenge when you're working at a national contact center to have that. There are some fantastic directories, and we can link to this, that are attempting to sort of bridge that gap nationally so that a counselor anywhere can go look up that information. But I think it really does make a big difference. And some counselors said through the survey, when someone is in another state from me, I struggle to be able to tell them about mobile crisis options, which, I can still dispatch them in an involuntary intervention. I can still contact a PSAP and make a dispatch happen, but it really makes it harder to do the engaging with the person in crisis on it stuff. Along those lines, a number of counselors also said that they were happy to have been trained in how to tell someone that they're on a 90-day call with that they are dispatching, that they're sending first responders, and that they are able to give someone a heads up even when it's an involuntary intervention. And as we know from numbers we've been talking about, this is a really small percentage of 90-day calls where there's an involuntary dispatch, but it is, I think, for a lot of people who are using or even considering using 90-day, a big consideration. Is this going to happen? And so some counselors said, well, when it does happen, at least we are equipped to have that difficult disclosure conversation and tell the person, I'm sending first responders to you. Whereas some other counselors in the survey actually said they are trained and expected not to make the disclosure. And some counselors actually felt uncomfortable with that and said it can be a challenge when I know that I'm sending first responders and there's going to be a knock at the door and it's going to be a surprise to this person. So it was an interesting area of a little bit of difference within the system, but I think there's always a positive when there's a challenge. And I think the positive is that in so many states and territories and at so many contact centers, there is pretty deep experience in 5, 10, 20 years of a track record of doing it one way versus the other. And especially at the contact centers that have been practicing this kind of disclosure for a long time and have a training and are able to support counselors in making it and teach crisis counselors how to have that difficult conversation. That's sort of, I think, a potentially really big untapped resource if we're able to take those learnings and techniques and the training on how to do that and spread it across the rest of the country.
Mm-hmm. Mm-hmm. So I want to get back to you on that point in a second about crisis counselor training. Monica, I understand that SAMHSA or perhaps Vibrant do provide like some sort of standardized trainings, or there are these training requirements. Could you talk a little bit about that piece?
Yeah, Vibrant does offer trainings that are available for any of the crisis contact centers. We encourage crisis contact centers to be engaged with the wide portfolio of training that is available through Vibrant. We also recognize that contact centers may also bring additional and have additional types of training to support their staff and employees, as they should. And so we continue to try to do everything we can to catch it at every angle, to make sure that that type of support is in place. It's just fundamental and just kind of foundational.
Okay. Thank you. It's great to hear. And then Dan, back to you. So it sounds like you identified in your survey some certain areas where maybe perhaps crisis counselors felt they could use more training. Could you talk a little bit more about that?
Yeah. Well, certainly this really varied a lot within the survey, which means that it varies a lot between states and between crisis contact centers, which I think just means it's always useful to check in with the folks at the front line. And I think ideally to have sort of an ongoing open channel to folks at the front line to understand, are they feeling trained and are they feeling supported on particular difficult kinds of interactions. So some counselors said, I feel generally well trained, but I'm struggling with, for example, abusive calls. Especially a lot of folks brought up sexual gratification calls as an area where some didn't feel they were trained or equipped with protocols that they were comfortable with or that really felt like they worked. Other folks said, I feel generally well trained, but I really need a lot more on SMI. I really would like to learn a lot more about different forms of serious mental illness and the way that it may be affecting people I speak with every day. So there was, and a lot of folks also brought up intent to harm others. What if I'm speaking with someone who is disclosing thoughts or an intent to harm someone or kill someone, including, unfortunately, but it is a reality. Things like school shootings, intent toward that. And some counselors said this is an area where this has happened, and I have not felt specifically trained on it. But I think on the high end, there were counselors through the survey who said my training was fantastic. I got many weeks of training before I took a single call, and especially what a lot of counselors really liked was when they had a chance to listen to real calls, or if they were doing chat and text, a chance to read real transcripts of conversations where they're seeing both ends. They're seeing what does an experienced, really, really skilled crisis counselor sound like or look like in any of these difficult situations, and what does the other end of the interaction sound like. So getting that exposure before your first shift, whether it's live listen-ins and shadows or listenings to recordings of calls, was extremely helpful, along with role play, along with the chance to practice those interactions yourself before you finish training. But unfortunately, some counselors through the survey said that those elements were actually not really part of their initial training at all, that the initial training was really compressed, in some cases down to about 2 weeks, and that it didn't include those listen-ins. And it was a similar pattern when it came to ongoing learning, where a lot of folks said ongoing learning is everything, because there was a certain amount I was able to absorb before my first shift, but and going forward, I benefit so much from whether it's listening to more calls and having a group discussion about techniques and special challenges. Um, some counselors said that they get that every week at their call center, or every month, or at least quarterly, whereas unfortunately other folks said that they weren't getting a lot, or in some cases any ongoing learning. And again, counselors pointed to an opportunity to bridge that gap, with the thought of why don't we sort of find a way nationally to pool some of what we have, especially if there isn't any confidential information in it. So especially if we're talking about a recording of a simulated 90-day call. That's the sort of thing where if there's one state or one call center that has developed some really great ongoing training material, could it be shared with the rest of the system, and could that really help fill the gap? Because I think, especially to Stephanie's point, a lot of counselors were very satisfied with being able to work from home and with being able to take their calls or their chats from home. But what that came along with was they're no longer sitting in a call center next to experienced peers as counselors. And I think there's a lot of learning that kind of happens through osmosis in a call center when you're surrounded by amazing, wonderful, experienced folks, and you can hear a little bit of their calls and talk to them during breaks. And I think it's important to find a way to make up for that with a move to remote.
Mm-hmm.
I mean, Dan's got a great point there about the working from home, because we see 31 some states say they're allowing remote telework because it's part of getting that staffing, especially the 24/7 weekends, holidays. But it does carry with it that, if you've got it's a traumatic, stressful job. And if you're working remotely, how do we make sure that we've got the adequate supports for people? There are some interesting models. There's one state that's actually got people that are part of their mobile crisis team are also answering calls. And they found it's really helpful to have them doing sort of both sides. And if the timing exists, even they've had the person who answered a call go out as part of the mobile dispatch. So they show up saying, I'm the person who you were just talking to on the phone. Let's deal more about it. And so that works in an urban area where you've got enough people, but it's sort of an interesting way to try and share the knowledge between the mobile crisis teams responding and the call centers themselves.
I would say that to that point, something we heard about too was how valuable people found the opportunity to cross train with other agencies, so that even if you don't have the call taker being the person who goes out with mobile crisis, that putting those entities together in trainings, bringing in law enforcement, co-response, 911, helped everyone to feel more comfortable that they knew what was happening once a call got handed off, but also made them feel more skilled at being able to communicate that to the caller themselves and being able to walk them through what they might expect from next steps.
Mm-hmm. Yeah, the this is we're jumping into the next question. So I appreciate the panelists on taking the charge on this. So we've talked about a lot of numbers, and then for folks who are following along with all the findings that Dan was mentioning, those can also be found in that report in more detail. What are the trends that you're seeing with the data, and what is the data? So we talked about the numbers, but what does it mean? What do you foresee in the next coming months, the next coming year? We heard a bit about SAMHSA's priorities at sort of the more state and local level. What do you feel that states are really grappling with, or where they're really looking to have some changes?
I can start there. I think some of the trends that we see, because the call volume is going to continue to increase. That is going to be as a result of more public education and awareness. So that's kind of to be expected. I think you're going to continue to see more states do active planning around building out their systems. I referenced earlier the amount of activity that's happening out there. You referenced legislation. There's appropriations out there. There's legislation like what you referenced. There's study commissions. There's all trust funds. So these things are going to be playing out. You referenced in California, there's a 5-year plan. So as these states continue to build out their systems, I think it's going to mean more people are going to be needed for the workforce, more skilled people. We're going to have to really think about what is really truly needed in the workforce. I was talking about this in a different space recently. You have to figure out how to use paraprofessionals and pay them accordingly. You have to be able to draw clinicians, particularly into these public spaces. So you have to be competitive. So I think these ongoing things are going to continue to be challenges because the system is going to continue to grow. But with that, I also say, but that's what we want. We have been a system that has been traditionally underfunded. Behavioral health has always been like the stepchild of healthcare. We don't do all of this thinking about how to respond if you are having symptoms of a heart attack. We know what to do for that. We are still talking about what to do when an individual is experiencing a behavioral health crisis. And so this trajectory in this moment in time, shame on us if we don't take advantage of capitalizing on the investments that have been made. The investments that the Biden-Harris administration has put into this has been uh, has been stellar. But we know that may not always be the case if like years from now. So we should be taking advantage and figuring out ways to sustain the things that are being built. We should be having these partnerships, state, federal partnerships, to be able to do this, private public partnerships. This is not just about the public healthcare system that typically is the safety net, that is typically the part of the entity that is forming and responding to all the crisis needs. Public health doesn't typically ask, what's your payer? We don't typically do those things. We just respond and we show up. But then you got to do the work. We have to do the work to figure out how do you sustain this. Medicaid can't be the only payer. We need all payers in the space, but we got to figure out how to maximize those things as well. There's untapped resources that we have to figure out how to tap into. So for us, it is providing technical assistance. It's addressing these things head on so that we can support states, territories, and tribal communities. None of which, if you've seen a state, you've seen a state. You've seen a tribal nation, you've seen a tribal nation. Nothing is the same. And so with all these differences, how do you really help support? And when I say technical assistance, I don't mean what we went and said, this is what we think you need, but that we're working with you to help you figure out based on your community what those needs are and how we can help you strategize. And so I think that's the work ahead. And it's going to be a big lift. This is not easy work. This is the most complicated job I've had. And I have had a lot of complicated jobs. It is big, important work. But if we don't take advantage of this time, then I don't know when we'll be able to change behavioral health from being the stepchild of healthcare.
Thank you. Thank you. Sorry, Ted, I'm going to ask you to follow up on that. For the kind of the trends that you're seeing at the state level.
There's a lot of, I think the big growth right now is we see 26 states planning to open more mobile crisis teams this year. There are 19 states reported plans to open 190 some more crisis receiving programs, alternatives to hospital emergency rooms, jails, EDs. places that are designed that law enforcement can take somebody and drop them off no matter what, and help stabilize them. We see a lot more state funds going in. The SAMHSA funds really helped jumpstart this, but the numbers we have right now is about $1.8 billion being spent on crisis services. It's gone from something that was almost nothing a few years ago to this really large expenditure. Half of it's state funds. The SAMHSA funds with the block grant and the supplements last year are really helping. Medicaid is stepping up. There's an enhanced Medicaid match for mobile crisis that a number of states are in the process of applying to get. The one issue that states are struggling with is they answer the call from anybody. They don't say, oh, you've got Blue Cross, Blue Shield, Kaiser, we're not going to answer. They send people out. And so in one sense, private insurance is getting a free ride and the public system is paying for services. And so there's been some discussion, is there a parity argument? How do we get private insurance to step up? There are some states that are talking with insurance companies, because if we keep somebody from going to an emergency room, we can save them a lot of money. I was on a call with a commissioner who said since 988 went live and they also put up a crisis bed board, their ED boarding has gone from over a day to under 4 hours for people with a psychiatric crisis. That's a lot of money saved that's not seen by the behavioral health department that could go into the system. I think the other area that states are really trying to look at is the whole workforce and getting downstream. So we've got a number of states talking with community colleges about, can you set up a training program for people, for professionals? A lot of work using peer specialists in the community, in the crisis continuum. NASHBID just did a report for SAMHSA's SMI advisor about how to hire peers with a criminal justice history to work in behavioral health services. Often having had an arrest is a barrier to employment, but these are people that know how to navigate the system, who are great to work on mobile crisis teams, on call centers, at crisis receiving programs. So that's a resource that's available from SAMHSA about how to change policies to hire people and not just say because you had a history of an arrest, you can't work here, when that may be helpful for the experience.
Sounds like a ton of innovation at the state level, which I think also kind of really highlights what Monica had said, that the initiative of 988 is not just a 3-digit number, but has catalyzed all of these other things, which we are now seeing following through the rest of the continuum of care.
Eric, can I add one more thing? Just because if I don't, I'll feel bad later. We cannot build a behavioral health system that is based on crisis alone. And so it is important, as we are building out these crisis components, that when the crisis is over, it is a moment in time. When the crisis is over, that the behavioral health care continuum has services and supports that are there built into the system before and after. Building a system just on crisis alone is building a house on a broken foundation. You have to have those other things in place. You have to have intensive outpatient services. You have to have the peer support services. You have to have children's services. All the things have to be in place. And so those are other things that have to happen parallel to building out this crisis system.
Yes, for sure. Stephanie?
I think the other thing that we're starting to see trend wise is more states that are moving towards legislation that are going to require things like interoperability. I know with a couple of the sites we worked with, and even in preparing to choose our 3 sites, we spoke to 13 in total. And most of them had decided that interoperability was something they wanted to do as a grassroots effort. They saw a need in their community, so they figured out how to make it happen. But we're seeing now that more and more this is something that's going to be required top down from the state level. California, as you mentioned, Virginia is another example. And so I think that's also going to propel some of the decision making and focus on services over the next few years.
Yes. Interoperability, quite a big word. Dan?
Well, with the survey that I'm speaking about, it was really just a sort of single point in time measurement. And my own suggestion, recommendation would be for lots of us to try to find ways to make it a more of a continual pulse, and to give crisis counselors, the frontline staff, more of a continuous way to voice both their concerns, but also their ideas. Because again, through the survey, a lot of counselors really shared some very brilliant suggestions for making things better, including on the workforce side, an idea of if someone is potentially burning out, being on calls 40 hours a week, and at the same time, if the place where they work is struggling to have enough quality assurance staff or enough trainers to do weekly or monthly continuing ed, or enough supervisors, which a number of folks said they wish that there were more supervisors on shift when they were on shift, because a lot of folks, unfortunately, said some of the time they struggled to get a supervisor's help. But some counselors suggested, well, maybe we can solve for all of this. Would take an experienced counselor instead of having that person be on the call for 40 hours a week. What if they were on for 20, and then they could spend those other 20 hours serving in those other roles and filling some of those other workforce gaps within a call center? And I think some crisis centers have actually started doing this in various ways, including also having counselors play a public education role or more of a community-facing role during part of their week. But I think there could be really a lot of value towards to get ideas like that and a pulse like this coming not just from an occasional national survey like this one, but coming constantly. I think it could be really helpful to set up advisory panels made up of frontline crisis counselors and to give counselors a direct seat at the table in conversations about how things are going and about policy. Bringing counselors onto panels directly themselves, so that there's a continual pulse. And potentially one other way to do it would be in systems where a counselor is documenting a call and writing up notes after a 90-day interaction. If there were a field or a little rubric where they could evaluate how well did they think the interaction went, as part of the picture. In a lot of cases, we have some evaluation data, we have some outcome data, and we have often some random sampling, listen in on calls, or random review of chat transcripts for quality tracking. But what would it look like if additionally, after every interaction, the counselor said, here's a rating for how well I thought it went? Could that potentially point to some trends and data that could be coming in constantly? Where the counselor, I struggled on this one because I didn't feel like I was equipped to make a local referral, or I struggled on this one because I was expected to end the interaction after just 15 minutes when I really felt like I needed 30 or 45. To be able to get that data coming in always, if a counselor spends half a minute interaction, I think that could potentially be a way both to have much richer data and for counselors to be able to participate much more in shaping some of this.
Yeah. Thank you, Dan, for highlighting the importance of involving counselors and a lot of the work and innovation that's going on at the centers that they work at. So we're going to shift now to some of the questions from the audience. And I apologize, we have a lot of questions, so more than 600 people registered. So we won't get to all of them, but perhaps one of the most common ones we got was about geolocation-based routing. And at least in our experience in California, one of the challenges from moving away from local numbers is the fact that routing has still been challenging. So Monica, could you talk a little bit about geolocation-based routing, how that protects privacy, and what kind of maybe timeline or updates on that might look like?
Yeah, so we are hoping, and it's very promising, that geo-routing will begin to go live this year. We are looking to the fall. If it happens earlier, then that's great, but right now, probably the fall. And so of the beginning of implementation of geo-routing. And what geo-routing is, because it's different from geolocation, we're looking at different solutions. We're in active conversations, testing solutions with some carriers. And what we're looking to is using, basically, the easiest way to say this, because it is complicated, is cellular infrastructure. So right now, as I said before, when you reach out to 988, it's tied to your area code. And as we know, many people do not have the area code of where they are necessarily living or where they're at. And so if I am in Arizona, I was in Arizona recently. So if I was in Arizona and I have an Atlanta area code and I dial 988, I'm gonna get sent to the contact center that is covering the Atlanta area. But if I need which would be okay if all I needed was the phone intervention, which is what most people need. The data shows that well over 90% of the contacts are resolved on the phone. But in the event that I need a mobile response, like a mobile crisis team, as we talked about, I was pinged to Atlanta, but I'm in Phoenix, and so this is something that we see as critical. It's my number one priority for this year. It's important for the growth and evolution of 988. I do respect and understand why states still have existing 10-digit numbers. For one, they've been in many instances they've spent decades building that brand. Their community knows that number. And so to expect that they would just all drop their numbers locally is not really reasonable, I think, as an expectation in these early stages of 988 being developed. But the number one reason why those numbers probably still exist is because geo-routing. With the 10-digit numbers, people know these, I'm going to get people that live in my state, territory, etc. And so it is my number one priority. And so it is geo routing or bust this year because that's going to be really important. So geo routing in terms of perception of it, I want to remind people you don't have to say who you are, so you still never have to disclose who you are. And it's different from geolocation, which is what the police are able to use. We do not. That's not what geo routing would be. It would just get us closer to the area, the vicinity of where you are. And so it's not meant to track. It's not meant to your privacy still is intact. And then if someone is being dispatched, a mobile crisis team, or there was a connection made because there is the concern of imminent risk or public safety, and 911 was brought in, these are conversations that should be actively had with the individual. This is not meant to be a surprise or something that they should be actively involved in what is happening, in the individual coordinating and communicating with the person, family member, et cetera, should be explaining step by step and making sure that this person is aware of what is happening. And so if someone was dispatched, it is because, like, if it's a 911 dispatch, it is because there is clear and present perceived danger or risk. And so we are going to make sure people are safe and alive when that is what we're faced with. And so that is geo routing. And so we, again, stay tuned, but it is all I think about every single day is geo routing.
Yeah. I also, when I was working on, I learned a lot of new technological terms, and I was like, I thought it would just be easier than this.
Yeah.
Getting a question that we've gotten that gets to the heart of the foundation's mission to decriminalize mental illness is that there was a concern among some advocates that 988 might possibly lead to more involuntary interventions or involuntary treatment or transportation response. And so what have folks seen? Has this concern been borne out? Is that something that you all are worried about in kind of the states and things that you've said?
I can start. We have not. That's not what we've seen. So right now we do not see that. The data does not point us there. Again, there is such a wide variety of the individuals that may contact 988. So there is a wide group of people who, like I said, may just need someone in that moment because they don't know what to do. It's not clear to them who they can talk to. And in many instances, people just really want to be connected to somebody that is listening, empathetic, trained to support them in that moment of time and give them resources. That is the vast majority. I'm using 90%. There's data out there that suggests it's higher than that. I'm being conservative in my 90%. That it is what, when you reach 988, that you're getting resolved without having to have additional support. And even then, when you look at, okay, if mobile crisis is now going out, and then looking at those the dispositions of what happened after mobile crisis, that still doesn't lead to necessarily involuntary commitment. So we want people to get the right level of support, the right level of care based on what the individual need is. The whole point of this is to be able to offer those other avenues so that people don't have that experience. there will be a portion of the population when you put out like who all reaches out, put the behavioral health population, you're going to have a portion of that is going to still come through involuntary. So now you're at the end of the continuum, right? The crisis continuum. That's not going to dissipate. But 988, we have not seen any data that has suggested that that has increased in any way.
And in California, I can echo on that. So our numbers of folks that are able, their concerns are resolved just through the contact, the phone call or text is over 95, closer to 98%. So we have not seen that here either. And an interesting study just came out this week in psychiatric services, looking at Arizona statewide data over 40,000 episodes of crisis care, which found that even if for folks who were brought in involuntarily, meaning that police perhaps dropped them off at the crisis center, that involuntary status was able to be removed while they were at the crisis center. So actually, perhaps suggesting that through crisis care, people could have more agency versus kind of what the system had been in place before. Do other folks have any other data points that they want to add on that from what they've seen?
Well, I think what we've seen, echoes what Monica was saying. Most of the calls to 988 or to crisis call centers are resolved there. It looks like, between 3 and 7% end up with a mobile crisis being dispatched. Of those that mobile crisis goes to, about 9% are transferred to a crisis stabilization program, because again, mobile crisis is addressing most of it. A few are sent to 4% or so to an emergency room. And then of those who go to a crisis receiving program, it looks like about 10% are then referred on for detox if it was substance abuse or for a psych hospital. So you have this huge pyramid of millions of calls going down to, many fewer people needing mobile crisis and mobile crisis addressing that, leading to a great reduction. There have been a few examples. Oklahoma did an initiative where they gave every law enforcement vehicle an iPad that connected to a behavioral health crisis worker, because in rural areas, often law enforcement got there first. And an evaluation of that initiative, law enforcement would show up to somebody in a crisis, hand them the iPad, hit the button and connect them to a crisis worker. It resulted in a huge reduction in the number of people that police were arresting, the number of people that police were transporting to an emergency room. The use of state hospitals went way down as they had that initiative in order to address it. That was so successful that Oklahoma now has equipped every law enforcement vehicle, state police and local, in the state with an iPad that connects to a local crisis counselor. So, if you look back to the try and reduce criminal justice involvement, I think having a good crisis system really can result in that. What's hard is to count that, really to figure out, we sort of have to do pre-post, because you can't say, well, we're not going to randomize and we're not going to give this person a crisis service and see what happens to them. But the pre-post data that we've seen from a number of places, Oklahoma, Georgia, Arizona, really shows that we can get better outcomes, keep people out of psych hospitals and out of jails with a robust set of crisis services.
Yes, and I think that also demonstrates like this notion that we have across the behavioral health spectrum of the least restrictive level of care, and it sounds like 988 has really been doing this in its year of rollout, and in fact even perhaps better than others. Our final question, someone of the panelists brought up the idea of public-private partnerships before. And so a lot of the kind of initial jumpstart has been federally initiated. We were lucky to have Congress, authorize and appropriate funds, and this office created to now administer and coordinate. But there are a lot of kind of gaps and pieces where there's opportunities for public and private partnerships, whether that's nonprofits or philanthropy. What do folks see as opportunities there, sort of like gaps that they think that could be a good spot for further support?
I could jump in just from my old hat of being in state government. There are so many opportunities. Philanthropy is always looking for ways, initiatives to support. There are so many ripe opportunities for a partnership between public and philanthropy work, tapping into those resources. Down at hospital, like private hospitals, large hospital systems, they do not want individuals with behavioral health sitting in their EDs, and neither do we. if we can divert. So how do you work with your hospital associations, your private big conglomerates, and say, hey, how can we help each other? I've seen those things work. I've seen some really unique and creative, innovative ideas that have been born out of that, because you're meeting the need of what the hospital wants, but you're also meeting the need of the individual and what we typically want as a system. And so, I mean, I can go on and on, but you got to be able to tap into, is this an area of interest? What's the yield, the gain for them, and see if you can match so that you can get those type of investments as well. And those opportunities do exist. It just takes somebody focusing on it. So somebody whose job is to do this is helpful. So just because of time, I'll stop there.
I think another interesting area for them is, it was really surprising. We said 8 states said that they're allowing mobile crisis teams to be dispatched working with schools. And the whole issue about, there's so many issues with police being called to schools for behavioral health issues. And if there's a way to try and help get school systems to use the crisis system as opposed to calling law enforcement for youth, and there's so many different school systems around the country that it's not a state to a state agency, but I think there's trying to understand what could be done and how to work there is an area that's ripe for some focus about how do we help better address the needs of kids experiencing a crisis that may be experiencing it while at school, and keep them from having the response be calling this security officer or the police.
I think another opportunity that we heard about is partnering with nonprofits, especially to provide culturally responsive services and reach groups that have been especially marginalized from behavioral health and crisis services in the past. We heard a lot of examples of things like partnering with local refugee communities and organizations that serve them, veteran serving organizations focused on LGBTQ plus populations. I think this is another way that we can really leverage the deep expertise of nonprofits and private entities that are working in this space.
Yeah, thank you. And Stephanie, I just wanted to follow up on that, because I think at the beginning you mentioned that your studies were funded by Pew Charitable Trust. And so as the system grows and needs further kind of refinement and monitoring, do you see that those types of support as continuing to be useful?
Absolutely. I know that organizations like Pew are starting to focus more on this as well, and also thinking about the role they can play, not just as a philanthropic funder, but also providing technical assistance and funding technical assistance. So I think there's a really key role to be played there.
Thank you.
Connecting to that point of Stephanie's, I think one question is, when an organization is able to provide counselor-facing material, training material, responder-facing material on working with certain refugee populations or LGBTQ populations or other populations, where can they, if someone has developed a fantastic training, where can they put it so that it reaches the whole system, so that every state and territory and every crisis center and every other responder has a way of accessing that excellent training? And to me, that's sort of the same question as what to do about how some states and some centers already have really fantastic counselor training material on SMI, on abusive calls, on homicidal intent, or even just on generally on active listening and some of the deeper parts of the core skills in crisis counseling. How do we get from where some centers and states have really fantastic resources, and others don't have access to it? And I wonder if there's a role to be played by foundations, nonprofits, or even schools of social work or clinical training programs, of basically just sort of being an aggregator of that and saying, anyone who has this kind of material and is comfortable with its being used nationally, send it to us, and we will host it. We will put it somewhere where it's accessible, where crisis counselors at centers across the country can come together and access it, so that it's not created here, but and available only here. It's available everywhere.
Thank you, and thank you to all of our amazing panelists. I think we're closing out our time, so I apologize again to the audience members who sent in questions we did not get to answer. I believe that hopefully those will get distributed to some of the panelists afterwards. So Melissa, I will close our discussion and hand it back over to you.
Great. Thank you so much. And thank you so much to all of the panelists for this provocative and really interesting conversation. I feel like we could probably go on for another hour, but of course, everyone's days and lives are quite full. In addition to a big thank you, I kind of want to just give a very brief reflection. We're clearly at a moment of great transformation and change. And this conversation has really left me feeling quite optimistic that if we all work hard to remain curious, rely on data, and get involved locally, statewide, and nationally, we can together transform the mental health care system, which will in turn increase access to care and ultimately decriminalize mental illness. So, again, I thank our panelists, our wonderful moderator, and all of you for joining us. We hope to see you at future Sozosei Foundation events, and I wish everyone a wonderful weekend and good health and humor going forward. Thank you.